Can you guys tell it's been a sleepless night? I got up at 3 o'clock this morning, couldn't go back to sleep, so I'm trying to get all this work done so it'll be all ready for you guys when you come in. So, um, with that said, we are going to talk about pediatric considerations in IV therapy. Ms. Candler has gone is going to go over the pediatric calculations for you since she is our pediatric specialist, and I'm going to hit on some of the IV complications and considerations we need to have with our pediatrics. So here we go. First I have to get off of the video, which I'm always glad to do. I don't like being on the video. Okay, so from the beginning. Here we go, Chapter 22. This is in your Pediatric Hockenberry book. It's your purple paperback. You were lucky this book was not one of the new editions that came out. We're looking forward to that next year, so we'll have to have a new edition next year. But for this year, we have the same edition. You don't have to buy a new book. Yay! First of all, we're going to talk about some general concepts you need to consider with a pediatric patient. A lot of times it comes up about informed consent. Now, there's a lot of things that we do to pediatric patients we don't need informed consent, and a peripheral IV is one of them. Even a scalp vein. If your infant is less than a year old, of course you need to check your policy of your hospital. The hospital policy at White River Medical Center here in Batesville is if a child is over 12 months old, you need to get the consent of your physician, and you may end up needing to get a consent of your parent. Usually not, though, for peripheral IVs, even if it is a scalp vein. But there are some things that we have to consider with informed consent. What the age of majority and the competency. Usually 18 years old, and if they're mentally able to make decisions and choices, has to be considered. They have to have those two things before they can sign for their own consent. Because a teenager of the age of 18 can sign for their own consent, but they are still considered a teenager. So they are still in that adolescent pediatric portion of care. Certain requirements that we have to have is that if they are underage, we have to be sure that we are explaining it very carefully to the parents so the parents or the guardian can sign for their consent. The guardian, if they are of age, if they're 18 or older, they can refuse treatment. Parents can refuse treatment for their child. If we treat them without consent, we can actually be charged with assault, and the hospital can be held liable for any damages done. So we want to be very careful to know what we need consents for and what we don't need consents for. Always remember that the physician is the one that's responsible for explaining the procedure, the risks, the benefits, and anything else about the procedure. When we sign the consent as a witness, that's all we are doing. We are signing the consent saying we have witnessed this patient's signature on this form, that they have agreed to sign this form, and it's not up to us to explain the procedure. Now, if they ask us questions, we can reinforce the procedure. If they seem to be a little uncertain, we should make sure the doctor comes back and talks to them again. These are things we just need to make sure we're looking at. We can also get verbal consent over the phone. Say you've got a child that's really sick and you need to have, the parents aren't there and you need consent for a procedure to do it right away. It takes two nurses listening to the consent, and they have to document that verbal consent was given by Mr. Smith for what procedure you've asked them to do, and both nurses have to document that. You may run into an emancipated minor. Pregnant women, even if they're 13, can sign consents for epidurals, vaginal deliveries, cesarean sections, because they are considered an emancipated minor in that situation. And some states actually grant legal emancipation to some of these children that are underage. The parental rights to see that medical chart, yes, they have actual rights to see that chart. So we cannot keep the parents from seeing the chart. Once the child turns 18 and is able to do their own consent forms, then situation changes. If a parent refuses to give consent, as situations you've probably seen where parents refuse to let their infant have blood, or they refuse to let certain procedures done, doctors can override that. Most state laws have laws that permit treatment without consent when it's life-threatening and not considered in the welfare of the child. So we are protected in that form if they don't give us consent. It really is a big ethical, moral decision that turns into a nightmare when you have situations like that. Okay, so we need to prepare them for the procedures. And of course, the procedures we're going to be doing right now with this particular lecture is going to be IV therapy. So we need to go in and prepare them to get their IV. We want to decrease their anxiety. We want them to be cooperative. Depending on the age of your child, depending on their developmental characteristics. Some children are developmentally more advanced than others. So we really want to make sure we do a very thorough assessment on that, and make sure that we are basing what we say and what we do based on that. We want them to trust us. You don't want to say, okay, your nurse goes in and explains to the child that we're going to do this, and we're going to, the child learns to trust this nurse, and then all of a sudden somebody shows up that's going to poke a needle in them. That makes it very difficult for the child. So we want to really try to make sure that whoever explains the procedure does the procedure, and establish that trust and provide them with the support. And of course, parents being present with an IV start's always been a little controversial as far as whether or not they want to be there. Most parents don't want to be there to see their child get stuck, but sometimes the child needs them there. Now, an infant, they won't know if their parent's there or not. But if the parents wish to be there and it's not detrimental, if the child's not clinging to the parent and you're unable to get to the site that you need to get to, then you may have to ask them to leave. But most of the time it's better to let them be there and support the child. And again, make sure that all your explanations to the child are age appropriate. There's a box on page 638 in your pediatric book that gives you a big long list of things that you can use. And try to respect choices that children have to a degree. If you can, if a child wants to be held by its mom during the procedure and they're willing to hold their hand out and let you start their IV but want to be held by their mom, that's great. That's kind of like a holding restraint by the mother or dad, and you're able to start the IV. But be sure and be careful that when you are giving a child a choice, that there is a choice to be made. You don't want to say, are you going to let me start your IV? Because we know we're going to start the IV. You might ask them, if they're which hand they want to have their IV put in, if possible, or something like that. But be sure that you're able to give them that choice. And then we go to performing the procedures. When I first started nursing, you had a treatment room to take your kids to do all their IV starts and any unpleasant procedures, because room was considered a safe haven for them, and they felt safe in that room. But when you go in the room and you do the procedures in the room with a child, then they don't feel safe in that area. However, at this particular point in time, with most hospitals do not have treatment rooms on the floors anymore for you to perform these procedures, and most all procedures are performed in the room. So we can't actually offer this to uh, be sure that the child has a safe haven. When you go in to start this IV on this kid, even though you really are dreading it because you know that kid's going to cry, you know they're going to fight, you know it's going to be hard. Some of the kids you're not going to be able to explain the procedure to, depending on their age. And it's very stressful for you. But you have to walk in that room like, I am a successful nurse and I am going to start this IV and we are not going to have any problems and you are going to cooperate. I don't go in there looking like you're defeated. Children pick that up real fast. If you can involve the child, if they're old enough to involve them, like even just helping hold the alcohol pad or help clean with the ChlorPrep, things like that, that you can actually let them do. It helps decrease their anxiety. Providing distractions, sing little songs to them, play a little game with them, let them blow bubbles away from wherever you're going to, of course, do your IV start. So these are things that you can do. Maybe have a possible TV in the room and have them watching a little cartoons or something. Always be very positive. Tell them how good they're doing, no matter how bad they are. All of us need this, right? We all need positive support. Negative support is not support at all. It's actually a tear down. So we all like positive feedback. So be sure we're positively, doing a real positive support for them. The use of play is awesome to use in procedures, dolls, equipment, letting them play with your stethoscope, things like that. There's a box 643 that gives you a lot of helpful hints on how to use play in procedures. Be sure when you're using play in procedures, you're using it toward that child's age and development. And you're going to learn all about growth and development in the next few weeks. And of course, you got to prepare that family as well for the IV start. Should they be present in the room? Should they not? If you're going to do a scalp vein, there's going to be a lot of blood. Should you tell the parents about that? Well, if they're going to stay in the room, you better be telling about it. If you're going to clip hair, should you clip hair? Yes. So always prepare the family for whatever. And when you go to start this IV, be sure you have enough supplies, because with a child, chances are they may jerk away. You may need extra tape. You may need extra this or extra that. So be sure you have extra supplies. Take 2 or 3 IV cathalons. Take a couple of extra band-aids, a roll of tape, anything you think you might need. Be sure you take any type of restraining or protective device that you need. Be sure you have everything in there that you're going to need. And a lot of times just putting kids down together and with a doll is very helpful. These kids even actually have gloves on like they're going to do the procedure. And you can see their developmental age kind of varies there. There's an older child, and then there's one that's not quite so old, but he's old enough to understand what's going on. You see he's got the ChlorPrep in his hand getting ready to start an IV on that baby. We've got a blood pressure cuff on him. So there's really all kinds of really neat things that you can do to help them to play out their fears. Of course, restraining methods are usually used in starting IVs on the very young children. Infants and toddlers usually have to be restrained. Sometimes the older children can actually participate and understand and cooperate. Of course, first of all, that's why we need to assess our little patient to see, do we need to have a restraint? Government, state, federal, every healthcare provider is trying to actually avoid using restraints at any cost. Therapeutic holding, where the child is held in close physical contact for about 30 minutes or less, can be done by either the nurse or the family member. So another nurse can start the IV if a nurse is holding, or family member, of course, is going to make the child feel more safe. The one that we use the most with our infants is the mummy or the swaddle restraint. There's also a the mummy bed that you can use. The pediatric floor at White River has a really great restraint board that they can use where you can restrain the baby and actually just have whatever extremity out that you're going to need. But of course the swaddle restraint works just as well for that. Usually with jacket, limb, and elbow, you don't see that used a whole lot unless you've got a child that's really resistant and tries to pull their IV out. We should try all types of alternative methods before we attempt restraints, and we should be documenting it. And that um, applies to your adults as well. Restraints are just something that, unless you have to use them, you need to be documenting you tried other methods first. And we want to be sure and, prepare a child for the best that we can to tell them why we're restraining them if they're old enough to understand. And here is our little papoose, or mummy restraint, whichever you would like to call it. This is the one you notice that they've got everything covered, but the only way you would do this one was if you were starting a scalp vein. You would want to have your extremity out that you're going to be using. These are your little elbow restraints. I have actually never seen these, but they look pretty cool, and they keep the kids from pulling at their IV stuff because they can't bend their elbows. All right, so how are we going to position them for a procedure? Of course, we're going to have to explain to them we're going to be doing this procedure, and we're going to have your arm or your foot. Are we going to put one in a foot? Well, not under a child, not in a child that's walking. If we have a child that's walking, we don't want to put anything on these in their feet, just like with an adult. Basically, in a child, the reason we don't want to put them in there is because of the restraints that it has on them, and they're going to be up, they're going to be walking, and you're going to lose your IV, and that's going to make you very upset. So, makes me upset anyway when I put in a IV and kid pulls it out, because it takes a lot of effort to get that IV in there. So, be sure we're providing our explanation. Make sure that we give them a little bit of guidance. Analgesia or sedation. Sometimes, especially if they go to surgery or something, they need a bigger needle or a bigger type of infusion device. We will see maybe sedation used, but most of the, or even analgesia, but most of the thing, a local anesthetic is a wonderful thing to use for a child that's going to get an IV that really knows that you're fixing to stick them, because it will keep them from jerking away from you. Emla cream is something that you can use. Emla cream is a topical analgesia. The thing about using Emla cream is you have to use quite a bit, and you have to cover it with a Tegaderm, one of the clear dressings, and it needs to be on the side for almost an hour before it's really actually works to numb the skin enough for you to do the insertion without any pain. One of the best things they've come up with is the lidocaine spray that they use mainly in the ER settings where you see it used, but it should be used on the floors to start IVs with just a spray. Now, of course, adults and older children, you can use lidocaine sub-Q and put your Capillon through that. But with really young children, they're not going to understand that's why they're getting two sticks, and they're not going to like it either way. So, if we could use something like that, it would be really wonderful for them. And of course, we're going to restrain them as needed. Our most common site for our venipuncture. With older children, we try infants and older children alike. We like to start with the upper extremities. Older children, you usually want to put that around in the forearm and up, as far distal as you can. But not in the hand, so that they can still use their hands. However, in an infant less than 12 months old, depending on how fat they are, but in a neonate that's 4 weeks old, the easiest spot to put an IV is in their hand, because their veins are more visible in their hands than they are anywhere. They have less subcutaneous fat on the dorsal part of their hand. I myself prefer a scalp vein, because you can actually papoose them down and have someone help you hold the head, and it's just a whole lot easier. Of course, it really freaks parents out, so we don't do that quite very often, but it really is a great place to put an IV. But it's not the preferred method or preferred spot. For the preferred spot is going to be the dorsal part of the hand for an infant. And here's a picture of mama restraining the baby. So it's a toddler, old enough to see what's going on. And actually, it looks like she's behaving very well, getting her venipuncture done. Now, we have all different types of IV devices: peripheral lock, heparin lock, saline lock. These are all the same thing. They are just the IV started, the metal part of the needle removed, the over the needle catheter is left in place, the plastic tube is left in place, and then we tape it down and we put some type of hub on the end of it, so we don't have tubes running to it, and it can be used intermittently. And so that's what any of these locks are. Most locks are saline locks, because they have research has shown that saline works just as well as heparin for flushing your locks. So this is usually where we start, and mostly preferred is the peripheral IVs, where they are actually in a surface vein. Then we have our central venous access devices. We're going to talk a lot more about these in adulthood. Different types that they are is the short-term non-tunnel. That's usually used something that's very, very acute care. You have a really sick kid coming in, do a femoral cut down, subclavian, and it's should have a chest x-ray before you use these short-term non-tunnel catheters for anything. In order to decide which one of these devices to use, you have to know why you're needing placement for it, how long your therapy is going to be, if they've been a hard stick, if they're going to have surgery. All these things need to be considered. If they're going to have long-term care, a lot of things going on there. Then we have the long-term tunnel catheter, which can have single, triple, double lumens, so you can have different lumens that you can do medications in one, fluids in another, give parental nutrition in another. So these are reasons you would probably want to use the long-term one. And then you have your implanted infuser ports, which is used for really long-term care like chemotherapy. It's also, if they're going to have one for very long, it's really nice to have that so that they can swim and not have to worry about pulling it out or anything, because it's covered with skin. PICC lines are widely used in the hospitals and in home care. Usually they are placed in an antecubital area into the basilic vein. So why do we do IV therapy in a child? Well, usually we're doing IV therapy versus intramuscular PO is because maybe they have some poor absorption related to diarrhea and vomiting, dehydration, then you have to get it in there, so they need to have it through the IV, or they need fluids in their IV. If we're trying to get the serum drug level up in their blood, we'll need to do IV so that we can get it in there quickly and get it built up quickly. If they're having resistance to infections, we need to use high-powered antibiotics and get to it quickly and get that level built up. If they've had some type of surgery or has some type of injury or leukemia or in a lot of pain from cancer, and they need continuous pain, they should have pain relief. They need to have an IV access so they can get their pain medications to them quickly. Any type of emergency treatment we might need to do, and of course if they're having any type of surgery done. Before we put anything in any of these IV sites or access, we need to make sure that our site is patent. So we always want to make sure that we're checking patency for the hip locks, the saline locks, the venous devices. Make sure we got good blood return with all of these venous devices before we use them. Don't ever administer IV drugs with blood products. Always give one antibiotic at a time unless it's ordered by the pharmacy and mixed together. And you do not see that these days. When I first started nursing, we mixed gentamicin and cliacin together and ran that together, but they don't mix those anymore. You simply because you don't know which drug is doing. If you had an adverse reaction, you wouldn't know which drug did what. With infants and children, to give any type of medication through their IV, because it should be given in a secondary tubing, should always have a syringe pump in use with that. Some of our two main complications of any type of intravenous device is going to be infection and occlusion, and we need to be watching out for those. And here are some of your IV devices. The Huber needle that you're going to be looking at doesn't look a lot like that. It's going to look a little bit different than that. So you can see where they have the dressing removed for your photo up there in B, where it's showing you the external CVL for you. And then they're not showing you, they've got the implanted port, and then it's showing you a side view of the port. And the first little picture up there is just showing you where everything goes, where your tubing is going to be going at. And they all go in a different place. When you are doing IV therapy on a child, you do not need a doctor's order, and you should not even worry about having a doctor's order to do intake and output. It is absolutely essential that you do intake and output on any infant, child that has IV therapy. There's a list in your book of all different things, different reasons why you should do nursing responsibility and do the measuring of the intake and output. I don't ever want to hear any of my students that are taking care of a patient, of a pediatric patient, come and tell me that they're not doing INO because it's not ordered. This is a nursing responsibility, and should you have a problem of a child that gets overload, gets fluid overload, because you didn't do INO, you can be liable for that because it is a standard of care. So be sure you are doing it. Measure all sources that come in and go out as best you can. Any, sweat, vomit, NG, everything that's come in, things they drink, ice, everything like that. Children who are not continent, your little toddlers and your babies, we weigh diapers. You weigh the diapers when they're dry before you put them on there. You weigh a whole bunch of them, and then you weigh the wet ones after when you change them. And approximately 1 gram of that wet diaper is going to equal 1 milliliter of urine. So if you weighed a diaper before, while it was drying, it weighed 20 grams. And then when you changed the baby, the diaper weighed 40 grams, you would record 20 milliliters of urine in that output. And then, of course, your NPO students, NPO patients need to have mouth care and make sure you're taking care of that. The bad thing about weighing diapers is sometimes the diaper's not on good and the pee can leak out and be on the bed instead of in the diaper. And then, of course, sometimes you will have pee and poop mixed together and you don't know which is which, but you do know you've had that much output. Parental fluid intake. Parenteral, excuse me, it's not parental. Parenteral fluid intake. When you're trying to decide where you're going to select your site and what type of equipment you should use, again, be sure you're considering developmental, cognitive, even the mobility of the child. If the infant's up walking, you don't want to use a foot vane if you can possibly avoid it. Older children, you want to try to be sure and choose a vein in the forearm and leave their hands free. We already talked about that. Avoid the favored hand. If they're right-handed, put it in their left hand. Don't put it over a joint, such as in the antecubital if you can avoid it. Never put an IV in the wrist site because there's a lot of nerves in that wrist site. And even though there may be a vein that's poking up there, you may hit a vein or hit nerves and cause some irreparable damage to the nerves. In the small infant, again, the dorsal hand vein is your first choice. Scalp veins are really great to use because there's no valves in those veins. You just want to make sure you're palpating the vein to make sure it's not an artery because the arteries run close to the skin on the scalp. Of course, you always want to clip hair because you're going to have to tape it down, and you can't shave it anymore because that's against policy and procedure of most hospitals. You must clip it. And if you do have to clip hair, be sure you save that for the parents because if you treat this as the first haircut, it doesn't freak them out quite so much as my baby had to have its head shaved in order to have an IV put in. So, usually with small children, a 22 gauge is plenty big enough, and for infants, a 24 gauge is usually what we use. The shortest catheter, smallest gauge for whatever therapy we're doing is what we should use. And a 24 gauge, even if a baby has to have a blood infusion, a 24 gauge is big enough because the blood, you only like where we usually give 300 to 400 milliliters of blood to an adult. 10 milliliters of blood in an infant is quite a bit, and it would go in slowly, so it would not damage the blood cells as it's going in because it would be going in slower. Those are some things that you would take into consideration. The interosseous infusion, we're seeing more and more of these, and they use them especially in the emergency room, and in the paramedics use them a lot in the ambulance. It's rapid, it's safe, and it's definitely used for some life-saving. You can't get an IV, and especially in a really dehydrated infant or child, you can pop that interosseous needle in there really quickly, and it can be used until you're able to get an intravascular route established. And they say in your book that it's really good to use it for a 6-year-old and younger, but they have actually been doing this in adults here lately. And it's been proven to be a really life-saving way to get fluids to someone who needs them and needs them quickly. Here is an interosseous. You see replacement. You see that it's an infant. So they needed this in there and they needed it in quickly. And it's rapid and it's safe, and they can give quite a bit of fluid at one time through there. Here are some devices that I want you to be familiar with for when you do pediatrics. In this area up here, this is what most people call a Buretrough. Buretrough is the actual trade name of this device. This is actually a micro chamber. So that you put in, up above here, this is your roller clamp, and up above this is the bag of fluids that you hang. So You want to put no more than an hour's worth of fluid in the Buretrough chamber itself, so that your pump goes off every hour, should be set to go off every hour. You should be checking your pediatric infant IVs at least every hour, if not every 30 minutes. But should never go more than an hour. There have been a lot of damage done to kids who somebody nurse thought they could just fill that chamber full and not check that site. So be sure that you are, when you do a child, small child, infant, that you have this device instead of hanging it directly to the IV bag. Sometimes the hospital will run out of these, and it's very dangerous to have a child on a straight primary tubing instead of putting this Buretrough tubing in there, or micro chamber. Try to get used to saying micro chamber. This little item down here is a syringe pump, and a syringe pump is the most awesome thing to use to give your medications to your patient that is pediatric patient. They are, you put your, well actually, the syringe goes here, and this is how it is inserted. The barrel is down here, and then your plunger tip is up here, and then you can actually, you have to make all these little choices up here as to how fast you want it to run, how long it's going to run for, what size your syringe is, and so forth. And then when then it will accurately deliver your medication. So you should be familiar with that. And I think Miss Kendler has PowerPoint set up for you guys as well. And here are some of our venous sites. This frontal vein and superficial temporal vein, these are good veins to use for your scalp vein. And they're pretty cool. And then you see you have this little dorsal network. You can see it makes a loop. So depending, you only really get a couple of chances on each vein there. And sometimes with kids we do the cephalic vein, the basilic vein. This vein down here, the great south venous vein, is a wonderful vein. I've started them in there, and really can get some fluid in that vein, especially if you need to give blood. And the little veins down here in the feet for an infant are a really good choice as well. Like I said, if you have one walking, you don't want to, or even crawling, you don't want to put an IV down there. They'd be better off to put it up here in the head. So how are we going to manage all these peripheral lines? Get used to calling them PIVs, peripheral intravenous lines. Well, securing them, we got to be sure that they have adequate protection. We have a thing now, y'all are lucky you have stat locks that you can put on them, protective dressings that are transparent that you can put on them. You never want to put an occluded or gauze dressing over to protect an IV, because you cannot monitor it, especially in a child and an infant. They have to be monitored. They infiltrate really easily. They can extravasate really easily. So you want to be sure that you're able to see that site and see it, check on it at least every hour. When you go to remove that IV site, be sure that you remove it. You can let the child help by maybe holding the Band-Aid for you till you get it out. So when you remove it, be sure you hold pressure on it for a minute or so and make sure that it stopped bleeding before you put the Band-Aid on. There's nothing worse than holding just a little bit of pressure, put the Band-Aid on, the parents come running out 2 seconds later after you leave the room and the Band-Aid soaked because you didn't hold it on there. And also, if you don't hold it on long enough, you'll cause some extensive bruising on the hand. So be sure you hold pressure on there for at least a minute or so. Some of the complications that we're going to see with it, of course, are infiltration and extravasation. So we want to be sure that we know how to handle those. Infiltration, of course, is where the fluid from the IV leaks out into the tissue. And sometimes it's really hard to detect in a child because they have little fatty hands. Sometimes you can't see if you have a scalp vein. Sometimes you don't see edema or swelling until it gets into their eyelids, and then you will see it. So you really have to watch carefully with children about this. When you have one that has extravasation, you want to stop the fluids, but you want to leave the Cathalon in place in case you have an antidote that you can actually administer into there that might help stop the necrosing of the tissue from the damage of the medication that's gone through, a caustic medication. So depending on what you have going on, an infiltration, you can go ahead and take it out. But if you have medication going in that you know is a vesicant type medication, then you might want you'll leave the Cathalon in, so in case you want to put medication to where that vesicant has leaked into the tissue. This little device is a wonderful thing. We used to cut the medicine cups in half and use them, but this is one now that we can actually purchase, and it's called IV House, and it houses the little intravenous site underneath, and it's a really cool thing to use as long as your kid is old enough not to pull on it and want to take it off. This is something that we use old school that's cheap and usually not easy to do. The ones we have, we call them fishnet because they're a lot. This is gauze, the stretchy, gauzy stuff, but it still has holes where you can see it. But the fishnet is even better because you can see better through it. And it's very pliable, and you can move your hand, and it's not as cumbersome as the house. And it's very cheap. Hospitals like cheap. All right, let's have us a question. We're preparing a 9-year-old boy before obtaining a blood specimen by venipuncture. What is an appropriate approach by the nurse? Are you going to tell him that it's not going to be painful? Well, that's not being honest. And one of the things we're going to stress during our program is above all things, you should have integrity and be honest in all things. So you can't tell him it's not going to be painful. That's not a good choice, is it? Tell the 9-year-old boy he shouldn't worry about losing a little bit of blood. Well, he's probably not worried about losing that blood, you think? He's worried more about how it's going to feel. So that's probably not going to make him feel a bit better. Encourage the patient to help with the procedure by holding still. Well, he's helping, so that makes him part of the procedure. So that would decrease his anxiety. So that's probably a very plausible answer. Let's look at D to see if it might be any better. Provide restraints and perform the procedure quickly in the patient's room. Now, we don't want to use restraints unless we absolutely have to. So we have to try the alternative, remember? So our best answer would be C. And I'm sure every one of y'all came to that conclusion. And that means that this is the conclusion to the pediatric portion.